Ladies and gentlemen, welcome to the Brilliant Mind Studio. Please give a warm welcome to your host from the University of California in San Francisco, Professor Michael Cabana.
Thank you and good morning. My name is Michael Cabana. I'm a professor of Pediatrics, Epidemiology, and Biostatistics at the University of California in San Francisco. And thanks for joining us this morning for the Brilliant Mind Studio. Our topic this morning is looking beyond infant colic, long-term consequences, the role of L. reuteri protectis in functional abdominal pain and other GI and other disorders. With me is a very distinguished panel. I have Dr. Stefan Roos from Uppsala, Sweden, Dr. Eva Hojsak from Children's Hospital in Zagreb, Croatia, and Dr. Ruggiero, or Professor Ruggiero Francavilla from the University of Bari in Italy. So there's been a lot of work that's been done in the last few years on L. reuteri DSM-17938 or L. reuteri protectis for infant colic. Several new randomized controlled trials on the effect on colic, and several meta-analyses which also show a positive effect for this particular probiotic for colic. But the purpose of this session is to look beyond infant colic to see if there's other applications, and it's also important to see if there's potentially mechanisms that we need to learn that will also give us insight into how this probiotic might be used. I guess we'll start off with specific mechanisms, and Dr. Roos, maybe I'll start with you. The World Health Organization definition of a probiotic are live microorganisms that, when ingested in adequate amounts, confer a health benefit to the host. So this implies a relationship between the probiotic and the host. What can you tell us about the relationship between L. reuteri and the host?
So, thank you, Michael. Lactobacillus reuteri is a bacteria that colonize different types of animals. It colonizes pigs, rodents, chickens, but also humans. What makes this bacteria very special from a microbiological point of view, but also from a probiotic point of view, is that this colonization seems to be very host-specific. So strains colonizing pigs to only colonize pigs, and strains colonizing humans to only colonize humans. So it's a strong host specificity we can see among the strains of L. reuteri. But also, looking at where we find it in the oral cavity, small intestine, mother milk, and vagina. Those, especially oral cavity, mother milk, and vagina, leads to it can be efficiently transferred from the mother to the infant.
So the World Health definition suggests a one-way one-way benefit for the host, but you've written about this mutual benefit as well too.
Yes. This strong host specificity also suggests that there has been a co-evolution. Those strains have been with us for many, many years, hundreds, thousands of years. So co-evolution that has led to a well-developed mutualistic interactions, because we have a mutual benefit. The benefit for us is that the bacteria can help us to shape the immune system and help us to regulate different functions in the intestinal tract. But for the bacteria, of course, we provide the bacteria with different nutrients and a home. It's also a communication. The bacteria has to communicate with us in order to colonize and in order to have those benefits, but also that we have to communicate and to understand the bacteria and provide it with different signals and nutrients. So it's a communication that is very, very important for this mutual interaction. And we think this is the basic for a strong probiotic bacteria. We have a strong host adaptation, well-developed communication, leading to true mutualistic relation, and by that, we think a stronger probiotic efficacy.
So the specific strain that you mentioned, this is L. reuteri. It's very general, but
yes,
there's different strain specificity. So I think as a clinician, I'm familiar with DSM-17938 protectis, but there's also Prodentis, so I guess that's important to distinguish as well too.
Yes. This is the 17938 Protectis that we have been using in most studies in infant colic, but also the strain we're going to discuss here today. But we also work with other strains. And to illustrate that they are very different and can have a strain specificity, I will compare it with this strain, PTA 5289, that we have in the product Protectis. They're both reuteri and share most of the properties that bacteria can share. But there are also hundreds of genes that differ. And those are the genes that are involved in host interactions, leading to that they have different properties. So the Protectis strain can reduce pain, have an effect on gut motility, but also it has a much stronger effect on inhibiting pathogenic microbes. So that differs it from the other strain, PTA 5289. But the PTA 5289 on its hands has a much stronger effect on inflammation, and it's much more it's better to colonize the oral mucosal surface. So they are different, showing that the strain specificity is very, very important here.
So Prodentis associated with inflammation, L. reuteri Protectis associated with reducing pain, improving gut motility, inhibiting pathogens. I think Protectis is what we're familiar with colic, and there's been, as I mentioned, there's been a lot of literature recently about colic. Maybe you could summarize where that stands in relation to everything else as well, too.
Yeah, thank you, Michael. As you already said, it has been done a lot of we know we have a lot of studies for randomized control trials, so evidence is there. And I would say that evidence is very strong. We have the strongest level of evidence for the usage of Lactobacillus reuteri Protectis in the children who have infantile colics. We have altogether 4 randomized control trials, 345 children which were included. And nevertheless, it has been shown on the individual patient meta-analysis that was performed and published this year that children who received the Lactobacillus reuteri Protectis and have infantile colics, especially if they are breastfed, the pain will decrease in the specific group of patients. Furthermore, which I found very interesting, is the recent meta-analysis, which was a network meta-analysis. So that network meta-analysis compared the usage of Lactobacillus reuteri Protectis towards not only placebo, but towards the other treatment methods or dietetic interventions or different methods that we usually use for the treatment of infantile colics. And as you can see here on this slide, you will see that actually the it is this one? This one, okay, thanks. So that the use of that specific probiotic strain is very efficacious when you compare it to other interventions that we are using. So we really have, I would say, really strong evidence to recommend it.
So this is an unusual way to display data, but this is the probability of best treatment against sucra values. Yeah. So you want to be as far to the right as possible. Yes.
Yeah.
Okay, and the further out the more effective is potentially useful.
Yeah.
So clinically we use it for infantile colic, but so potentially there's a use for functional abdominal pain. It's always important to start with definition. So what's the difference between colic and functional abdominal pain?
Yeah, the functional abdominal pain was defined for many years now. But recently, I would say with the development of Rome criteria, we had more stringent definition about not only functional abdominal pain, but also all the functional gastrointestinal disorders. And when we talk about the functional gastrointestinal disorders, then the subcategory in that vast majority of the disorders is functional abdominal pain disorders. And functional abdominal pain, which is not otherwise specified, is together with irritable bowel syndrome, dyspepsia, and migraine considered as functional abdominal pain disorders. So these are the disorders that we often see in our kids. And when we talk about the functional abdominal pain disorders, we as clinicians, we see patients who are usually older than 4 years of age. They come to our office and the parents and the child is saying that they have a pain in the middle of the stomach, that the pain, it's not interfering with just regular, or it's not interfering with the diet, eating, stool, but it actually interferes very hard with the activity of a child. And sometimes those children tend to have very high school absenteeism, and that's the amount of the days that they are missing school is comparable to the amount of days that we see, for instance, in very severe organic gastrointestinal diseases. Furthermore, it is also the quality of life which is really impaired in that group of patients, and we tend to forget that because we think it's a benign disease, it will go away. But the thing that we see is that those children really have a high school absenteeism, which may put them in a very difficult position. And on the other hand, the emotional burden that those children are having is the same, regardless whether the pain is organic, caused by an organic disease or the functional disease.
I agree, it can be very disruptive to families. The question that families ask me is, and my medical students ask me is, what's the etiology or what's the cause? So what can we say about that?
Yeah, for the etiology of functional abdominal pain, the one thing that we know currently is that this is a multifactorial disease. So we cannot point in only one event or one pathomechanism which causes a pain. We consider it to be as a brain-gut axis disorder. So there are some events which can be early in life, but also some psychological events which cause a psychological trauma and putting those children in a risk to develop the functional abdominal pain disorder. On the other hand, we have different things happening in the gut of those kids. We know that recent gastrointestinal infection is a risk factor. We know that those kids have different gut microbiome when you compare it to the healthy proportion of kids. So this is really something that we see. We also see that those children have a mild inflammation present in their gut, and they also have a difference in the motility. So in a part, this is also a motility problem. And all that causes a visceral hypersensitivity, and that visceral hypersensitivity it causes a trigger for the pain, and sometimes they cannot cope with the pain, causing again and again exacerbation of the pain episodes. I would say that the reason why we have so many theories and so many changes in the pathomechanisms of the disease, that's why we have a lot of treatment options which were tested or at least we are giving them to our patients. However, when you go to the literature, then you will see that, for instance, for pharmacological treatment in children, the level of evidence and the trials are really, they are weak, they are limited, so therefore we are lacking the right pharmacological treatment. And therefore we moved from pharmacological to non-pharmacological treatment, and which was, for instance, to do dietary interventions. And we know that if we decrease the lactose intake in those children, we are not doing any benefit. We do not have enough study for that. There are some studies for hypnotherapy or behavioral therapy, but those therapies are not widely available even within the Europe. And therefore, we moved slightly towards to try to change our microbiome, and we moved towards this the concept of the probiotic in abdominal pain.
So many of my patients or families will also ask what the evidence is behind probiotic intervention. So where do we stand with the evidence here?
So with an evidence, we have altogether 10 randomized control trials, which were used not only for functional abdominal pain, but for functional gastrointestinal pain disorders. And I would say that 2 strains here are considered to be well investigated. One is LGG, and the other one is Lactobacillus reuteri Protectis. You will see that more than 700 children were included. There was a difference in the trials which investigated them. So for instance, for the LGG and for the multi-strains, most of those studies included the children who had irritable bowel syndrome. And when you compare this to Lactobacillus reuteri Protectis, most of the studies were done in children who have functional abdominal pain. Almost all children that were included had a functional abdominal pain. So there is a difference when you compare one type of studies to another one.
When you described functional abdominal pain a couple slides ago, there were different components. So it's quality of life, it's the severity or the intensity, duration of pain. What's the different breakdown on the different components?
So luckily, the studies tend to look at the similar outcomes. So first, most of the studies, they look at the severity or intensity of a pain. And as you can see here, most of the studies which were performed, and I put here only the effect of functional abdominal pain and not on the IBS. And you will see here that for the Lactobacillus reuteri protectis, there is overall a trend towards the decrease in severity or intensity of a pain. And when you put that and you show the exact results from the studies, then you will see that those two studies, one performed in Italy and the other one in Israel, they had quite a similar concept. So they used the probiotic for 4 weeks. They found a significant decrease in pain intensity, which stays also after the probiotic was discontinued. We in Zagreb, we used the probiotic for a longer period of time, but we evaluated our results at the month 2, 3, and 4. And as you can see here, there is a significant decrease in the pain intensity in those children. Again, only starting after the 4 weeks.
It seems very I'm just looking around because maybe some of the authors of these papers are here in the audience, but that looks pretty consistent over time. There's a bigger drop in the yellow bars than the gray bars. This is intensity, so the other important thing is keeping kids back and getting kids back to school. So the duration is also very important too.
Yes, duration is important. A number of days with or without pain is also important. For that outcome, the evidence is not so strong, so it's not so consistent. Weizmann's study and our study, we showed that those children have a higher number of days without a pain. So in our study, as it was a longer study, we found that the children who received the Lactobacillus reuteri protectis had almost doubled the number of days without the pain. Mm-hmm. So it's not going only to the intensity, but the highest evidence we have for the intensity, but it seems that also increases the number of days without the pain.
Yeah, one of the interesting things about one of your previous slides is many of these studies were done after 2015, so just in the last 3 years, yeah, there's been a lot of work. So, the next question is mechanism. So, Dr. Roos, what explains this potential mechanism here? How would you explain this?
There are actually 3 different ways, 3 different types of interactions that we think can be important here and can explain the effect that we see on functional abdominal pain. The first is actually a direct effect on pain. This was a study conducted by John Bienerstock and his co-workers in Canada. They looked at a TRPV1 receptor. That is a receptor that can sensitize distension of the intestine. And when that happens, it starts to signal, and you have a pain signal coming up to the brain. So this receptor, TRPV1, also reacts on capsaicin. Capsaicin, that is the hot chili, what you sensitize when you eat hot chili. So this is the model. It was performed both in animal models and in a cell culture model. So capsaicin binds a receptor, calcium is transported, and there is a pain signal that can be recorded. If they add Lactobacillus reuteri protectis into this model, to the animal or to the cell culture, they can see that the bacteria can actually block the signals.
So it's a receptor blocking.
So it's a very efficient receptor blocking of the bacteria and also recording pain. They can also see that the pain goes down in the animals. Mm-hmm. This is the first way. The second type of interaction is on the intestinal barrier. As you know, this is the key for a healthy gut. And this was a model that was done, experiments done by Mark Roos and his co-workers in Houston, United States. So they looked at inflammation. They induced inflammation in a rodent model by challenge with LPS.
That's LPS. That's lipopolysaccharide. Yeah.
Yeah, exactly.
Okay.
So as you see here, this is the ileomucosal surface after this challenge, and you see those lesions that the mucosal surface has been damaged by the LPS, causing inflammation. but if it is at the same time introduce Protectis, Lactobacillus reuteri Protectis, this is what you see. The bacteria protects the epithelial cells, so mucosal barrier will be protected, reduce permeability, but also reduce inflammation. This is the second type of mechanism that we think can be important here. And the third and last is the actual on-gut motility. Once again, this was performed by John Bienenstock and his co-workers. They looked at gut motility in an ex vivo model. They took out the intestine. In this case, it was a small intestine from a mice. They put it in a water bath and can record the gut motility. Now it starts.
So you're actually making it move. There you go. Okay.
Yeah, so now it runs. This is the control. This is how it looks like in a control animal. And this is how it looks when you have introduced Lactobacillus reuteri Protectis. So you see it slows down considerably here. So it goes slower. So the frequency, but also the velocity goes down in the small intestine. I think this can also be implicated that it's less crampings. If this will also happen in the infants, there can be less crampings.
So there's three potential mechanisms that's been postulated. Maybe they're complementary, or they're competing, or they're you can consider them all together. But TRPV1, the effect on permeability, and then this effect on motility, which can be potentially associated with cramping. How does that correlate clinically, Dr. Hojsak, with what you see? It seems that a receptor blocker effect might be more immediate. Something on permeability might take a little bit longer as well too. But what do you see clinically with your kids?
It is hard to say. I would say we have the effect that we see on the randomized controlled trials. The problem with that is that most of those trials, they looked at the effect at the time period of 4 weeks. So this was the first time period when we looked whether there is an effect. Maybe effect happened earlier, but for instance, when you say that whether we can clinically recommend and the duration of the probiotic usage, I would say based on the evidence that we have now, that would be 4 weeks.
Okay.
Maybe in the future, if we would aim to do individual patient meta-analysis, in that case we will maybe see what is the time point where we see in majority of our patients, where is the time point when the pain control starts. But currently, at least based on the evidence that we have, I would say 4 weeks.
I like to apply the evidence that I see in the literature as closely as possible to my practice with my own patients. So you would recommend, so the duration of treatment you would say is about four weeks. Okay, great. Thanks for that summary. One of the other areas besides functional abdominal pain is also functional constipation. Professor Francavilla, can you update us on functional constipation? Always good to start with definitions, and it looks like you have a definition there, and what the current advice is.
Yeah, thank you, Michael. As we know, constipation is a big problem in pediatrics. Up to 30% of pediatric population may suffer of this condition. 40% will develop these in early time, in the first year of life, mainly when they change formula or at weaning, and also later on because they start watching TV, playing, so they withhold. Now, when it comes to definition, nowadays we have these Rome-4 criteria that applies to children. Slight difference below and above 4 years of age, but mainly for the diagnosis. Once you have excluded, the red flags, you must have 2 out of these criteria. So 2 of you have defecation in the toilet per week, at least 1 episode of fecal incontinence, history of retentive posturing, history of painful or hard bowel movement, presence of large fecal mass in the rectum. Once you have these, you have the diagnosis. And nowadays we do have a drug because we have polyethylene glycol that is work very well both in disimpaction and in maintenance. However, we know that it's not a magic drug because 10% still need the drug for longer than 1 year. 40% still have symptoms while on polyethylene glycol. And 50% will still have recrudescence of constipation in the next 5 years. So the idea is having something more that you can add or using long term would be very, very useful. And the idea of probiotic, that it is so safe, is actually appealing. But then we go to the evidence, And if you look at the evidence, if you ask, do probiotic work in constipation infancy, you come with this, that the routine use of probiotic is not recommended. And this is because there is no really strong evidence to support their use.
Maybe we can walk through some of that evidence.
Yeah, sure.
Yeah, sure.
Because, there have been published 2 meta-analyses. This is the latest in 2017. And what you really see at glance is that you have in 7 trials have been treated about 500 children, but in 7 trials you have 6 different strains. Very different doses. In 2 trials, probiotic was used along with a stool softener. So it's very difficult to gather all this information. And also when you look at outcome, you see treatment success, that it was at least having 3 bowel movements per week without fecal incontinence, was present just in 4 trials. Only defecation frequency was present in all the 7 trials. Frequency of fecal incontinence and abdominal pain just in 5 trials. So it's very difficult to gather the information. But at the end, when you do it, you see the effect here in the meta-analysis just is on the no effect. So it looks like that there is no really effect of this probiotic. This is for treatment success. And here you see defecation frequency. This is very strange because this is the same probiotic with complete different results. No effect on fecal incontinence, no effect on abdominal pain. What is more interesting, Michael, is the fact that in the same year, a new meta-analysis has been published. Now, with the same data available, they find just 6 trials, and out of these 6, just 3 were the same as in the previous meta-analysis. And this meta-analysis actually shows that probiotics may have an effect, but just in Asia. So if you want to do a business, go there.
Okay. Well, I'll tell my colleagues in Asia about that and my friends in the Philippines as well, too. So where does this lead us? Is there maybe data in adults, or what's the next step? And the other thing is, a lot of these charts, usually the charts are quite long. There's only 1 or 2 studies, too, so that seems to be an issue, too. But is there any other data or any other insight that you can show us?
Yeah, I think that usually, as for pediatrician, it's always best to go and see adult data, because when you look in adult data, you find a lot of studies. And indeed, probiotics, in adult study, you have 21 randomized control trials. That in this trial, more than 2,600 patients have been treated. And so you see here, this is the effect of the meta-analysis. You see that out of these 21, 11 show that probiotic actually work in increasing bowel movement of about 1 bowel movement per week, and in decreasing intestinal transit time of about 15 hours. So it seems that in adults there is much stronger evidence. The good thing of this meta-analysis was that the authors were actually focusing just on bifidobacteria and the lactobacillus. So it's kind of already selected the type of probiotics to look into.
And Protectis, is there data on Protectis?
Yes, we do have, because this is the one of study that was published in Italy. Actually, I know very well this investigator. He was actually using, he randomized 60 adult patients to receive either placebo of Lactobacillus reuteri 17938, and he used the Constipac as a score to assess patient. This is a constipation scoring system that takes into account also quality of life. And what he was able to show is that after 15 days of boostering, because he gave twice the usual dose to these patients, they went on taking for 90 days standard dose, so a cup twice a day. And you see here, after 60 days, you have significant benefit of Lactobacillus reuteri in improving this constipation score. And this is still maintained at the end of the trial. So I think this is very good data, at least in adults.
Yeah, that sounds encouraging. That's the first time I've heard of the Constipac score. So thanks for teaching me that. Any other insights in terms of perhaps the microbiota or other mechanisms? Stefan is here, so maybe this is a good time for a discussion about that.
Yeah, you know, it's very, gut motility is quite complex to look into, because you have to take in consideration that it starts with central nervous system, enteric nervous system. There is a dialogue between the two with gut-brain axis. Then you have to take in account luminal environment, immune system, endocrine signaling, and of course microbiota is just there and piloting all this information. And there are several ways in which gut microbiota can alter motility. If you think that germ-free mice, they have very slow gastric emptying, very slow intestinal transit time, but if you colonize with the non-pathogenic microbiota, everything seems to go back to normal. And the reason why these microbes may act on motility is because they produce peptides that can stimulate the entire nervous system, and also because they produce a lot of short-chain fatty acids. And these act directly on nerves, on smooth muscle, and also they may increase the release of serotonin that we know is very useful for the motility. And then, depending on each microbiota, some microbiota in constipated patients produce a lot of methane, and this methane actually slow intestinal transient time. And at this, on this topic, we have this paper. These also adults. It is from Italy. And this author went on and looked at the production of methane in constipated patients. And they were able to show that constipated patients, the production of methane is increased. What they did then, they randomized this patient to receive either placebo, is in gray, and Lactobacillus reuteri in yellow. And they were able to show that after 4 weeks, reuteri is able to decrease significantly the production of methane, and this parallels to a significant increase in bowel movements. So there is a proof of concept that you can actually treat constipation reducing methane production in the microbiota.
Dr. Roos, any other thoughts about mechanism from your work?
Actually, in the same model that was I recently showed when you saw the gut motility in the small intestine, performed by Jon Bienerstock and his co-workers, they have also looked at the colon. So they, in the same model, they put a piece of the colon from the rodent, and they start to record the movements, the gut peristalsis. And what you see here is a plot showing the peristalsis. This is the colon in the control animal, and you see it goes quite slowly. This is what happens after reuteri has been added. So it goes up actually with more than 100%, the velocity and the frequency of the bowel movements in the colon.
So that's another potential mechanism on its effect on constipation. What's the, I guess it's always good to go back to the evidence. So evidence with kids or evidence with adults?
Yeah, we do evidence with the use of Lactobacillus reuteri in constipation. And we can start from infants, because this is a study by Flavia Indrio that is here in the audience. And she was the first to see whether Lactobacillus reuteri could be used in prophylaxis to prevent infantile colic. And one of the outcomes that she observed was also number of evacuation per day. And as you can see, after 1 month and after 3 months of administration of this probiotic to healthy infants, because those are not constipated, of course, you still have an increase of bowel movement as compared to placebo, meaning that this is a kind of concept that this probiotic is actually working on increasing motility. I don't know whether this is good news for the mothers, because they have to change many diapers, but you know, it at least can let you think that this works on motility. Then we now go to this other study. This is by Cocorul in the group of Anna Meieria Stagliano in Italy. Those are constipated infants. They treated 44 infants, aged 2 to 8 months, and they give this probiotic for 8 weeks. And as you can see here, after 2 weeks, you have significantly number of patients who achieve this normalization of bowel movements. And you see, after 4 weeks and 8 weeks, in their experience, actually all infants receiving this probiotic achieve the goal. So it looks that actually it works in infants. When you go to children, now we have a head-to-head comparison between Lactobacillus reuteri and lactulose. The author randomized 100 children to receive either lactulose or Lactobacillus reuteri. And as you can see here, at baseline, there is no difference in number of bowel movements. There is no difference in stool consistency. But after 4 weeks, there is a significant increase as compared to baseline, and no difference between Lactobacillus reuteri and lactulose, meaning that, at least in their experience, Lactobacillus reuteri looks to be as effective as lactulose. When then it comes to side effects, the good news is that flatulence and abdominal pain is significantly less in patients who had received Lactobacillus reuteri, because we know that lactulose is the side effect is mainly abdominal pain and flatulence. So actually you are achieving the same goal without giving side effects.
So you started out, so I have to ask, you started out talking about the current guidelines. The current ESPGHAN guidelines don't recommend the use of probiotics for constipation, but there's at least 1 or 2 studies that suggest that DSM-1793 or Protectis is useful. Why isn't that incorporated in the guidelines? Is it the depth of evidence or the applicability?
I mean, the main reason is because there's just 1 trial in infancy and 1 trial head-to-head comparison in children with lactulose. So I think that you really need more evidence. The problem is that as a group, probiotics seems not to work. But nowadays we know that the effect is strain-specific. So we might need more studies with this probiotic or with other probiotics to gather all the data maybe in a meta-analysis, as Eva showed us for abdominal pain. But we need the same probiotic, we need the same protocol, we need similar doses. So in that way, we actually gain the information that is still missing.
So maybe as the evidence builds up, a lot of this has happened relatively recently, and as the evidence builds up, maybe there'll be changes to the guidelines perhaps.
Yeah, I think that yes, once the evidence is there, it should be in the guidelines.
You know, one of the hard things in San Francisco to enroll patients is once they hear about a successful treatment, it's really hard to get a family to agree to be in the placebo group potentially. Yeah. So it's very hard to have placebo controls in some pediatric studies. I don't know if you found that as well too.
Yeah, it is actually difficult, because if you have standard treatment, you have to go for the standard treatment. But on the other hand, you can actually see where the probiotics may add something to this standard treatment in terms of duration of treatment. They might actually need less drug or for fewer times, or they may actually prevent relapse. So I think that there are a lot of aspects to
I
study.
Think the lactulose study is a nice comparison as well, and the decrease in side effects.
Yes, sure. This is something that families really take care of.
So one of the nice things about these conferences is not only do you talk about the current literature and where things stand, but also future directions. So sometimes you need to crawl before you can walk. So that's what reminds me. So where are we now with any new studies that you're planning?
Yeah, actually, I was interested in reading this paper that appeared this year in journal Neurogastroenterology and Motility, in which the author were able actually to look at SIBO in patients who were candidates to proton pump inhibitors because of GI reflux disease or because of gastritis or functional or dyspepsia. So what they did, they had these 120 patient candidate to treatment and 120 controls. They start doing a breath test to see SIBO, and you see here, SIBO was in 6 out of 120 control, and in none on the patient who actually would have been treated with PPI. The very important information is that after treatment, you have now 36 patients that after PPI develop small intestinal bacterial overgrowth. These patients were randomized to receive either placebo or Lactobacillus reuteri 1798, and look, the one who actually got a probiotic, now just 4 have SIBO. So it seems that these probiotics may be able to prevent small intestinal bacterial overgrowth in a setting such as the PPI, that actually increase significantly the risk for this condition, because we have meta-analysis showing this. And the other important information is that when you go and look at how many patients have symptomatic SIBO, none out of the 4 have symptoms, meaning not only that it might prevent SIBO, but significantly reduce symptoms associated with the small intestinal bacterial overgrowth.
So how many patients are you going to need to study?
Yeah, actually, we are planning now this study. This study will be held in our university. And this is aimed to see whether we can actually prevent side effects related to use of PPI in infants and children. We will enroll almost 200 patients. They will be randomized to receive either lactobacillus reuteri combination or placebo. And they will be treated for 8 to 10 weeks, depending on the indication for treatment with PPI. And we will monitor several aspects, because in older children, we will do a breath test to see whether we can confirm the SIBO experience that I showed you before. And we will do also fecal collection, uric collection, to see whether we can prevent alteration of gut microbiota using probiotics, because we know that if you take PPI, you increase also the chance of having Clostridium difficile infection. So, and also we will go, and look at symptoms to see whether using probiotic along with the proton pump inhibitor, we can decrease symptoms associated with this drug and reduce the infection risk.
So it looks like it's going to take a couple years to do that study,
yeah,
maybe?
At least.
Okay. We'll look forward to reading your abstract at a future ESPGHAN meeting in the future. Thank you very much for that summary. We actually, why don't we open this up to other questions, if that's okay with you? We have microphones at different parts of the room, but please feel free to ask any questions that you might have, or we can clarify any issues as well. Go ahead. Do you want to use the microphone, please? Just tell us. Yes, thank you very much.
Thank you very much for such a good discussion. And I have a question regarding using this probiotic among infants. And in studies you have demonstrated us, what was the type of feeding used? Was it bottle feeding or was it breastfeeding? And how do you think, is it any difference in clinical effectiveness among two groups?
Yeah, actually, in this study they were breastfed, but I think that in this we do not have a lot of data to see whether it might actually work better in one condition or the other. So I think that at the time we can actually try either in breastfed or formula fed, and we actually need more data. Speaking of probiotic in constipation is quite difficult, because there is a really, let me tell you, lack of data. So it's something more like a feeling that you have when you do trial or you read what has been done that let you think what to do. My feeling is that at least in the first year of life, whatever you are having as a feed, if you have constipation, you may actually try to take a probiotic.
Okay, thank you.
Great. Question?
Good morning. I'm Dr. Arvind Gar. I'm from Noida. I'm Delhi. I'm a practitioner practicing in a private hospital. My question is, that with the use of this, how do you prevent the misuse of this drug? Because I believe the commonest cause of crying is a hunger. The parents, when so we have a medicine, we'll give the medicine, they'll not feed the baby. It's just because baby has been crying, baby is swallowing so much of air, there's so much aerophagia, for which they will using this. So this is where there has to be a proper guideline from ESPGHAN, from the body, that this is where it should be used.
Okay. So the question's specifically more about colic. So how do you prevent the misuse of the probiotic for infant colic? So that's a great question. So I can start and just tell you my approach. usually if I see a child on my schedule and the chief complaint is colic, I know that that's at least a 30-minute visit with a family. It's going to take a lot of time just to do a complete history, to do a very careful examination, and to reassure the parents, because it's a diagnosis of exclusion, and there's no test that I'm going to order. So once I've ruled out all those other issues, then and only then is when I'll suggest that. So I think it still doesn't mean that you can avoid doing a thorough history and doing a thorough physical examination and reassuring the parents.
I presume this has been done. That's what I'm telling you.
Okay. But I do think that goes a long way in terms of reassuring parents. And it's only going to be effective if they're adherent to the medication plan. So that's always going to be very important. But Dr. Hojsak?
Yeah, I have to say that I definitely agree with you. You are making a diagnosis of infantile colics based on the clinical impression that you are getting from a child. And if the child is receiving food regularly, it means that the child is thriving well. And if the child is thriving well, it means that the child is not hungry. Therefore, it is really important to know that this diagnosis is there. And regarding the misuse, currently we do not have any evidence that the usage of the probiotic in that early age, and we have now evidence of the follow-up of kids for many years, that is causing any side effects.
It is expensive. It's expensive.
Yeah, the economic cost.
It's expensive. So that is, that's a misuse. So you're using a drug but it is not needed.
It depends what do you think that the child is not needing the probiotic. If you have a parent who is concerned and they are already there that they are concerned as much to come to the hospital, it means that they are seeking help. And currently, the evidence that we are having, especially for the breastfed kids, I'm not talking about infant formula fed kids because the evidence is stronger for the breastfed kids. We have an evidence that the lactobacillus reuteri is working, and that is a strong evidence. So that can be your starting point when you recommend this to the parents. The question that I could get at the bottom of the one that you are asking, it is related to the price. We know that the probiotics are expensive, but however, currently we do not have any regulatory body which would put the probiotics to be covered by the health insurance.
And I just want to add too, one thing that we learned when we did the Sung meta-analysis that was published in Pediatrics is the Sung study wasn't as successful. And one of the differences was the probiotic was usually started when the infants were older. So as you're approaching 3 months of age, if I know there's light at the end of the tunnel and they're going to get better, if they're coming to me early when the child is 4 weeks or 5 weeks, then I know there's a really good chance there's time for it to have any effect. But if they're hitting the point at around 3 months where you know it's going to crest, perhaps then you can hold back too. And that's one thing we learned from doing the Sung meta-analysis. So I hope that's helpful.
Thank you.
Thank you.
Thanks.
Also, Michael.
Yes.
There is also the observation that at least in Italy we use a lot of type of probiotics. Sure. So if you combine all the information also of the doctor that just made the question, we can say that we really need what to use. Mm-hmm. So we need guidelines to say which probiotic to use in which condition, just to use the right one and spend in a good way our money.
That's a good point. I don't think there's a specific guideline, and that can help decrease some inappropriate variation that might be occurring.
There aren't guidelines. However, this is the only strain that we have evidence that is effective. Sure. So if the parents need to spend money on the probiotic, then definitely we should recommend the one that we have evidence for. But I agree that the guidelines are needed.
Hi. Over on that side? Yeah. Go ahead.
Thank you very much for enlightening us on the latest updates. My name is Dr. Tayyeba Bhatt. I'm a working pediatrician from Pakistan. And I just wanted to know what the latest recommendations are on use of probiotics in preventing necrotizing enterocolitis in preterm infants.
Okay. Necrotizing enterocolitis. So I am a general pediatrician. I see well-term babies, but we could talk a little bit about it. Do any of you want to?
Yeah, I can point out that first the working group of the ESPGHAN, who deals with pre and probiotics, we very recently published the network meta-analysis. So you can find it on the JPGN website, that it is available to be downloaded. And currently we are working on the guidelines, and it is mainly in the hand of our neonatologists within the group to give the guidelines on when to use the probiotics, for what outcomes to use it in premature born babies, how long to use it, and which strains to use. So first, I would not go into details now, but you have the network meta-analysis, which is really available at the JPGN site. And I hope by the end of this year we will also have the guidelines with a specific strain recommendation.
I think that's been one of the difficult things. It's like the constipation literature, many different strains tried, not a lot of depth. So it's hard as a clinician to get specific guidance, but it's good to know there's a guideline coming out. And that's an ESPGHAN guideline? Or?
Yeah, those are going to, it will be a ESPGHAN position paper.
Okay.
And these are the frail group of patients, so we really need to be cautious in that group of patients.
Okay, great. Sir.
Thank you. I'm Mitsugu Fujita from Japan, and I have a kind of basic question. And did you have a chance to evaluate the distribution of reuteri in either infants or animals after the administration of reuteri?
The distribution in the
distribution,
GI tract.
and which part of the intestine is the predominant?
We're all turning to Stefan.
Yes, I can take that.
Go ahead.
It's, I mean, in animals, I mean, that's a completely different situation. Then we can see that reuteri colonize for quite some time. In humans, we can also, what we have done in some studies is to detect the reuteri in fecal material. And that doesn't show where it, I mean, colonize in the intestine. We don't know what happens in the small intestine. We can't go down there and take samples.
Using PCR or some kind.
So yeah, so we can detect the bacteria in fecal material by PCR. And cultivation. So the bacteria is there during the treatment, a couple of weeks after, but then it disappears.
Do you think there is any ways to evaluate in infants? No.
Healthy infants, I think it would be hard to.
I know.
Yeah, there are some data showing that it can colonize also the stomach.
Oh, really?
And because it has been done with the fish. And this is the idea that actually this probiotic can work also in conditions that involve your stomach. And this is the reason why we have used this probiotic for a long time in H. pylori infection, just because we know that it can also be in the gastric mucosa. So I think there are, and also in the ileum, it has been fine. So I think this is a kind of probiotic that maybe because this is mutualistic with in ancient time, it's able to be all around the GI tract.
Yeah, we know that it efficiently can bind, attach to the mucosal surface, but it doesn't stay forever.
Yeah, it doesn't stay.
No.
I see. Thank you very much.
Okay, thank you for your question. Sir.
Good morning, everybody. I'm Ekong from Nigeria. Thank you for the presentation. My question has to do with the effect of the probiotic with respect to pain in terms of the characteristic of the participants that were given the medication. Because we know that for some people, they have variation in terms of pain threshold. So for somebody, excuse me, that has a high threshold for pain, some may have low threshold for pain. So assessing pain in these children is one thing one will need to be very sure about. And then the second is the use of the probiotic and then its effect. We could achieve an effect in the short term, but in terms of long-term effect of the probiotic, is there a way to assess if the effect is a continuous effect beyond the 4-week duration of therapy? So for how long will the effect be sustained? Is there a likelihood that the patient could still develop pain much later or could still get constipated much later? And then what may be the effect also of the diet on the recurrence in terms of possibility of recurrence in view of the fact that the patient may not all come from the same social strata. You could have some patients from high economic and some from the low socioeconomic group. And then what they take in terms of diet will also differ. So putting that into consideration, what do we look forward to see and think in terms of responding to possibilities in the future?
So there's three parts to your question. One is perceptions of pain or pain thresholds might be different.
Yeah.
The duration of therapy, and then the third part is the effect on diet.
Yeah.
So
I will go and say just from the back. First of all, functional abdominal pain, they occur all over the world, which is really interesting. So the incidence is quite the same, whether you go to Asia, Africa, Europe, or North America, or South America. So that is really interesting because the type of diet really differs between those countries. Furthermore, regarding the assessment of the severity of the pain, studies used always standardized scales for the assessment of pain. Certainly we know that the threshold of the pain is not the same for everyone, but therefore we use the randomization in order to have the same, let's say, same type of patients in both groups. This is the only thing that we can scientifically do to decrease the bias in that perception.
and you're checking against the baseline as well too.
Yeah,
so,
we check it
so
at
in
the
a way,
baseline.
every
Yes.
patient's their own control or their baseline.
It is in the diary, it is checked on a daily basis, so everyone was placing in whether the pain is there, and if the pain is there, what was the severity of the pain. And it was the same for sure for both groups. And the third question is, for that question we do not have an evidence. We know that the effect is sustained for 4 more weeks after the intervention because all the study used the follow-up for 4 weeks. Whether the effect is sustained for a longer period of time or the pain will reoccur, that was not investigated by the studies, but definitely that could be of interest.
Eva, how long was your study? It was 4 months?
It was altogether 4 months, 3 months
Okay.
of intervention and then 1 month of follow-up.
And it looked like it was sustained
Yeah.
across the four bars,
months.
so perhaps 4 months. Great. I hope we answered your questions.
Yeah, you have, but it's just in terms of practicality and the use in vis-a-vis costs. So it would be nice to know in terms of long-term follow-up. 1 month follow-up, I don't think is enough. Okay. So after therapy, it might be needful to follow up the participants much later, so that we'll see 6 months, 1 year, what happens. Okay, thank you.
I'm really sorry because we're right at the end of the hour, but I know my guests will continue to stay here to answer other questions, but thank you very much for coming so early in the morning and for staying so late. So thank you very much.
Thank you.